Imagine this, a hospital right in the middle of a severe crisis, like a critical shortage of essential supplies. Sounds like something straight out of medical drama, yeah. But this actually happened. It was a stark reality for healthcare systems not too long ago. And it forced them to innovate, really innovate under immense pressure. Out of that challenge came something pretty ingenious, kind of unexpected: intravenous push antibiotics, or IV push. So today on this deep dive, we're going to unpack the whole fascinating story behind IV push. It's basically delivering meds quickly with a syringe instead of that, slow traditional drip bag, our mission. To figure out if this method, which was really born out of necessity, might actually be a better option that we should be using more widely.
Exactly. And to do that, we've pulled together quite a bit of source material for this deep dive. We're looking at comprehensive clinical studies, insights from infectious disease docs and pharmacists, and a whole bunch of real-world reports on how this has been implemented. Yeah, the goal here is really to boil it all down for you. We want to extract the key nuggets of knowledge, the stuff about safety, effectiveness, the practical upsides, and also the more nuanced clinical things you need to consider with IV push. Basically, we're aiming to give you a shortcut so you're really well informed on what's a pretty crucial topic right now.
Okay, let's unpack this then. The history here is super important, right? We're talking about these really severe IV fluid shortages that basically forced hospitals and clinics to completely rethink how they did things. These shortages popped up after big natural disasters. Hurricane Maria in Puerto Rico back in 2017, that was a huge one because Puerto Rico makes a lot of this stuff. And then more recently, Hurricane Helene in 2024. But it wasn't just hurricanes. I mean, these IV fluid shortages, they've actually been messing with supply chains since like 2007. It feels like a real MacGyver situation for healthcare, pulling solutions out of thin air almost.
It really was. And because of these disruptions, a lot of places had to start conserving their IV mini bags. So they converted as many antibiotics as they could over to this IV push method.
And here's the wild part. They often did this without a whole lot of solid safety data, specifically for the push method at the time.
Yeah, it was a scramble, real scramble, just to keep patient care going.
So paint the picture for us.
Yeah.
How different is this from the usual way?
Okay, so the traditional method is called IV piggyback or IV PB. That typically involves either a premix solution or maybe a drug they reconstitute, put into a small IV bag, maybe 50 to 100 milliliters. And that's given as an infusion, usually over at least 30 minutes, sometimes longer.
Right, the slow drip.
Exactly. 5E push, though, is defined as a rapid administration. We're talking typically 3 to 5 minutes. It's a concentrated drug solution from a syringe using minimal fluid volume. So yeah, it's a pretty fundamental shift in delivery.
And this is where it gets really interesting, isn't it? This crisis solution starts revealing all these unexpected benefits. Let's talk about speed first. How much faster are we talking, and why is that such a game changer?
Oh, the time savings are pretty dramatic. 5E push seriously cuts down the time between a doctor ordering the antibiotic and the nurse actually starting to give it. There was a 2024 study, Brady and colleagues, they found the time dropped significantly, from an average of 74 minutes for the old IV piggyback method.
74 minutes, wow.
Yeah, down to just 31 minutes for IV push.
That's less than half the time.
Precisely.
Yeah.
And when you think about sepsis, for example, the Surviving Sepsis Campaign guidelines from 2021, they stress getting antibiotics in within the first hour of recognizing sepsis.
So that 43-minute difference?
It's huge. It becomes incredibly impactful. There are studies showing like a 7.6% decrease in survival for every hour that septic shock patients don't get antibiotics in those first 6 hours after their blood pressure drops.
Wow.
So it's not just, making things run smoother. It's potentially shifting the curve on patient survival in critical situations.
That's really powerful stuff. And okay, beyond the direct patient impact, you mentioned cost savings, like a ripple effect economically. What are we talking about money-wise?
Yeah, the economic benefits are substantial too. Using IV push means you don't need as much of the expensive IV tubing, the IV bags themselves, or equipment like infusion pumps.
Makes sense. Less stuff needed.
All right. And it also cuts down significantly on staff time, both for the pharmacy, mixing things up, and for the nurses administering it. We've got some concrete examples. One study estimated about $40,000 saved just by switching first-dose cephalosporins to IV push in the emergency department.
40,000 just for that.
Yep. And that Brady study we just talked about, they estimated savings of over $227,000 a year. That was just for 3 common antibiotics, ceftriaxone, cefepime, and meropenem, across their emergency departments.
Whoa.
And there's more. An evaluation at Parkland Health, they saved over 500 liters of normal saline solution. Plus, With reduced supply costs and drug costs, they saved an extra, what was it, $43,652 over just 6 months.
That's amazing.
And on top of that, they calculated about $550,000 in cost avoidance over 6 months because nurses spent less time and patients potentially had shorter hospital stays.
So these aren't just like small change savings.
No, not at all. It's a really significant financial impact. It frees up resources that hospitals desperately need for other things.
Okay, so it's faster, it's cheaper, but it's not just about the clock and the budget, right? You mentioned people. Tell us about the patient side of things, especially for folks maybe doing this at home.
Absolutely. The patient-centered benefits are really important, especially in what are called OPP programs, outpatient parenteral antimicrobial therapy. That's where patients often give themselves IV meds at home.
Right.
So the Yagnik study out of Parkland Health found that patients actually learned the IV push method much faster. It just has fewer steps.
Yeah.
Think about it. It's often just a pre-filled syringe they inject into their PICC line. That's a common type of long-term IV catheter.
Simpler is better, especially when you're doing it yourself.
Exactly. And they found patients had a higher pass rate on the teach-back before discharge, meaning they felt more confident and competent doing it on their own. Patient satisfaction was also way higher. Over 96% said they preferred IV push.
Why? What did they like about it?
They mentioned the shorter administration time, 5 or 10 minutes for a push versus maybe 30 to 60 minutes for a slow infusion. Big difference when it's part of your daily routine.
Yeah.
Plus, they liked the convenience and said the instructions were clearer. It just improved their quality of life during treatment.
That makes a lot of sense. And building on that, you mentioned shorter hospital stays, that Parkland Health study again.
That's right. They also saw a statistically significant decrease in the median length of stay in the hospital. It went from 15 days for patients on the traditional IV drip method down to 12 days for those getting IV push.
3 days shorter on average.
Yep. Which, again, reduces healthcare costs, but maybe more importantly, it lets patients get home sooner. And that's usually a huge plus for them and their families.
Okay, so faster, cheaper, better patient experience, maybe shorter stays. This all sounds great. But the big question always comes back to safety, right? Especially since, as you said, this was adopted quickly, sometimes without tons of initial data. Were these efficiencies gained by cutting corners on safety?
That's the crucial question, and it's definitely one research has looked into. The evidence we have now is actually pretty reassuring. Marsh and colleagues did a study back in 2020. They looked at 100,000 patients getting IV push beta-lactams. Those are common antibiotics like Astronam, ceftriaxone, cefepime, meropenem. Out of those 1,000 patients, they only observed 10 adverse events that might be related.
Only 10 out of 1,000.
Yeah. And half of those were allergic reactions, which, can happen with any antibiotic, regardless of how it's given, not specific to IV push.
Okay, what about the other 5?
4 were cases of neurotoxicity, nerve-related side effects linked specifically to IV push cefepime. And 1 was phlebitis, which is vein irritation from IV push ceftriaxone.
So some potential issues, but rare.
Exactly. And their conclusion was that the overall rate and types of adverse events were pretty similar to what was already known for the traditional IV piggyback method. And other studies, like those by Rabar and Academia and their teams, looked specifically at the emergency department setting. They also found no significant difference in adverse drug reactions between IV push and IV piggyback.
Okay, so it seems generally safe, but there must be some key things to get right to keep it safe in practice. You mentioned reconstitution. What's critical there?
Yes, reconstitution is absolutely vital. The key is usually to reconstitute the antibiotic powder with sterile water for injection SWFI. Not always, but often. Why? Because sterile water generally helps minimize the concentration, or what we call osmolality, of the final solution.
And why is low osmolality important?
Because if the solution is too concentrated, if the osmolality is too high, say generally above 600 millimoles per liter, giving it through a peripheral vein, like in the arm, can cause significant irritation, inflammation, that phlebitis we mentioned, or worse, extravasation injury, where the drug leaks out of the vein and damages the surrounding tissue.
Ouch. So using the wrong diluent, like maybe normal saline or D5W when sterile water is needed, could cause real problems?
Potentially, yes. It depends on the specific drug and the resulting concentration. Some drugs are okay with saline, like cefepime 1 gram in 10 milliliters of NS is common, but others, like meropenem 75 grams, often need 10 milliliters of sterile water. You have to follow specific guidelines.
So it really comes down to process.
Absolutely. The key takeaways from various guidelines are things like standardize your processes across the institution, update your policies and protocols, provide really good education for pharmacy staff and nurses,
Adjust the electronic medical record order sets so the right elements and volumes are prompted. Make sure you stock the right products. And crucially, use clear, standardized syringe labeling. Get those details wrong, and safety could be compromised.
Got it. And just a quick note here, based on the sources we looked at, the safety and feasibility of doing IV push in pediatric patients, well, that still seems pretty uncertain. Not enough data yet.
Right. That's an important caveat.
Hmm.
Now, shifting gears a bit, here's where things get more nuanced. While IV push has all these advantages we've talked about, it's not necessarily the perfect solution for every drug or every patient, especially when we talk about certain types of antibiotics like the beta-lactams we mentioned earlier, penicillins, cephalosporins, carbapenems.
Okay, what's the issue there?
Well, their effectiveness, how well they kill bacteria, is what we call time-dependent. It's not about hitting a super high peak concentration. It's about keeping the drug concentration above a certain level, the minimum inhibitory concentration, or MIC, for as long as possible during the dosing interval. We call this TMIC, time above MIC.
Right, so you want sustained levels, not a quick spike.
Exactly. And that's why for some serious infections, especially with these drugs, you often see prolonged infusions, maybe over 3 or 4 hours, or even continuous infusions over 24 hours.
Which seems like the complete opposite of a rapid 3 to 5 minute IV push.
It does seem contradictory at first glance, doesn't it? This is where the pharmacokinetic and pharmacodynamic PKT studies come in. They try to model and understand this tension.
So what do those PKPD studies actually tell us? Can IV push still work for these time-dependent drugs?
It's a mixed picture, and context matters. Some studies, like one by Liu and colleagues, suggested that for cefepime, IV push might be less effective if the bacteria you're treating has a higher resistance level, meaning a higher MIC, say 2 milligel or more. The push might not keep the levels high enough for long enough.
Okay, so maybe not great for tougher bugs.
Potentially. However, another study by Butterfield-Cowper and colleagues looked at several different beta-lactams. They found pretty minimal differences in the actual free time above MIC. That's the time the active unbound drug is above that critical level when comparing IV push versus standard intermittent infusion.
Interesting, so maybe it's not always a huge difference.
It suggests that for many situations, particularly if the bacteria are highly susceptible, meaning a low MIC, or if the infection isn't super complicated or deep-seated, IV push beta-lactams might still provide adequate exposure.
Okay, so theory aside, what about actual clinical outcomes? Where has IV push clearly shown it works well in practice?
Right, the clinical data is key. We see clear benefits in a few areas. First, the emergency department, and for those critical first doses in sepsis. Studies by Grigorovich, Lim, and others found that while IV push didn't necessarily change overall mortality rates compared to other methods, it definitely resulted in quicker administration and completion of those first antibiotic doses.
And we already know how critical that timing is.
Exactly. So it's considered a very reasonable approach for getting those initial time-sensitive doses in quickly. Second, we talked about the OPIA setting outpatient therapy. That Yagnik study again showed no difference in important clinical outcomes. Things like 30-day or 1-year hospital readmissions, ED visits, or even mortality rates. Patients doing self-administered IV push at home did just as well clinically as those on traditional IV piggyback.
That's compelling for those specific scenarios, but then let's flip it. Where does the data suggest we need to be more cautious? What patient groups or infection types might not be ideal for IV push?
This is where we really need to be careful. The picture looks different for critically ill patients, particularly those in the ICU. Several retrospective studies raised potential flags. Sherman and colleagues looked at critically ill ICU patients getting IV push ceftriaxone. They actually observed a higher rate of treatment failure, almost 38%, compared to about 19% in the IV push group.
Wow, that's a big difference. Treatment failure meaning the antibiotic didn't work.
Essentially, yes. The infection wasn't adequately treated. Smith and colleagues saw something similar with empiric cefepime, meaning given before they knew the exact bug in the ICU. 4V push was associated with more than double the odds of treatment failure.
Okay, that's concerning for ICU patients. What about other drugs?
There was a study by Johnson looking at meropenem, another beta-lactam often used for serious infections. They compared IV push to extended infusion in critically ill patients. Now, they didn't find a difference in the percentage of patients who eventually got clinically stable, but they found that the patients getting the extended infusion reached clinical stabilization significantly faster, a median time of about 20 hours, versus over 66 hours for the IV push group.
So push might still work eventually, but slower, which might matter a lot in the ICU.
It certainly could. Also, going back to the Marsh study, they specifically noted that we need more research on IV push dosing strategies for difficult-to-treat organisms, ones that tend to have higher MICs, like Pseudomonas aeruginosa, or for infections that are deep-seated, like bone infections or abscesses. The quick push might not penetrate well enough or stay long enough.
So the bottom line for these tougher cases.
The bottom line is, for critically ill patients, those with known or suspected difficult-to-treat bugs, or those with deep-seated infections, the decision on how to give the antibiotic push, intermittent infusion, extended infusion, really needs to be made carefully on a case-by-case basis, considering the specific patient, the likely bug, and the site of infection. 4V push might not be the best choice there.
Okay, that's a really important distinction. So let's try and synthesize this. We started with this story of adaptation during shortages. What's the big takeaway for you, for the listener?
Well, I think the big takeaway is that what started as basically a workaround, a forced adaptation, has actually revealed some really significant, genuine advantages for heavy push antibiotics in certain contexts. We're talking real gains in speed of delivery, major cost savings, better patient satisfactions, especially for outpatient therapy, and maybe even shorter hospital stays. It's a powerful example of how necessity can breed innovation.
Yeah, it really is, but it's not a magic bullet.
Definitely not. It's crucial to reiterate that nuance. While IV push seems ideal, even preferable for things like first doses in the ER, managing sepsis early on, treating uncomplicated infections, and definitely for OPAT, we absolutely need that nuanced understanding of the PKPD, the pharmacokinetics and dynamics, and the clinical outcome data, especially when dealing with critically ill patients or those with more complex, difficult infections. That's where the benefits might be outweighed by potential risks or reduced efficacy.
So it's about using the right tool for the right job.
Precisely. It's not a one-size-fits-all solution, but it's become a highly valuable tool in our antibiotic toolkit when used appropriately.
So what does this all mean for you listening? I think this deep dive really highlights how sometimes challenges and constraints can push us to find better ways of doing things, ways that are more efficient, more patient-friendly, and even more cost-effective in healthcare. And it makes you wonder, doesn't it? Think about other areas in healthcare, maybe even outside of medicine, that rely on these long-standing standard practices we just do because, well, that's how we've always done them. How might a critical rethink, maybe sparked by some unexpected pressure or shortage, uncover similar significant improvements? Improvements in efficiency, cost, or patient experience that we're currently overlooking? What other push innovations, maybe beyond just antibiotics, could be out there just waiting for a crisis or a critical eye to bring them to light and reshape how we deliver care? Something to think about.